This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 46 of the No Stroke Podcast. I'm Dave Dansereau. I'm here with my co-host Michael Garrow. Good evening, Mike. Give me some good news, please.
Good news. I just got new internet installed.
Okay.
Obviously we have some people who you might be living in remote areas of the country have to deal with laggy internet, but I'm in New York City in a tiny little apartment, and I've gotten kicked off about 4 calls in the last 3 days because my internet just keeps going out. So here's to Verizon Fios. I have full faith in our new internet and hope it'll serve us well.
Well, we'll test it out on this recording. So let's cross our fingers. So, you back and settled in. You had trip out to Texas last week, and you're back to work here. And
yeah, I think it's, definitely a bit more time to reflect. I do want to touch on the fact, in the intro last week, it kind of spoke to that survivor caregiver voice not being part of ISC, but, that was before we had a brilliant speech from Senator Leon, and he really spoke from the heart. I think it was a great message he shared, and the fact that it often takes that lived experiences to see the gaps, right? So for someone in his position, obviously as a senator, there's other people, obviously John Fetterman as well, who went through a similar experience. There's starting to become more of a discussion around stroke and the gaps in care. He specifically spoke to the disconnect of life after stroke and access to resources, and what kind of blatantly said it shouldn't matter where in the country that you had your stroke, no matter where no matter what your zip code is, why can't you get that access? So for those who were at ISC and kind of, or those not, I just want to clarify the fact that the American Stroke Association did make sure that voice is represented, and we're actually in discussions with the senator's legal team to hopefully have him on the podcast here.
Yeah, so Mike, I'll just feed up that because you're right. We actually recorded the opening when you were wrapping up. You had one more morning, which is when you sat in on that session, and including our guests who will be coming on, and we'll do that intro shortly. But just to feed off your point about the survivor experience, I actually just took a phone call from a stroke survivor who I wasn't even aware. I helped them about 1.5 years ago, getting over getting them some access to some equipment when things were shutting down so they could continue their home therapy. But they had tuned in to the last episode with David Petrino, and what really resonated was a comment that you had made about you used your future mother-in-law as an example in terms of adapting to technology and being able to get access to some of the services. Now, this person who will go unmentioned really had quite a bit to say, but he said, what you guys are doing is so important. He said, but I don't know how we're going to solve, and he used his own case in point. And he said, I'm at a point where, and this gentleman has some issues with aphasia, and he's working through, the top things that were priority were for him to get in and out of his house initially, then to continue to have some continued rehab at home. But now he's at a stage where he's returned to driving. And he mentioned that, he hears in the news, like the case of Senator Fetterman, who's been very vocal about, he hasn't hidden that he has some language processing issues going on, and he has the equipment to be able to adapt and be able to continue to do his job. He said, many of us just don't, we need that. We need something. He needs something to go back to his his job, and that's the barrier that is stopping him from being able to go to the next level, and he wants to return to work. So it came at a time where, it was it was busy week getting things, squared away on the home front here and everything. And then to hear that, it was nice to get feedback, because, we do this before and after hours. And a lot of times it's nice to get listener feedback, especially when, like I mentioned, this particular person, I didn't even know they were listening to our show. So we always welcome that. And it also comes in a time when, I'll be honest with you, it was, I was encouraged to, I don't know if you saw it, but I was encouraged by some faculty down at State University to put in for a TED Talk. And I actually, put my name in. Unfortunately, this morning found out that I didn't make the cut on that. So, it was a little bit of a kind of a little bit of a gut punch, but just, it goes to kind of what we talk about a little bit at the end of this episode about stroke isn't sexy, right? I think you even alluded to in the conversation that, you can't make stroke sexy, but you can advocate for life after, and it has to be more and bigger than individual survivor and caregiver efforts. We've put a lot of these pieces connecting, but when you hear a survivor say, how can I get access to that? I don't have an answer. It's hard.
It is, yeah. And, I think, part of what we're doing is, trying to represent this, the voice of, survivors, caregivers all around the country and the world, really, who experience these issues. And it's a problematic, thing. Again, it's not, something that's just experienced in one part of the country. Like it's an issue everywhere. And it's a very hard problem to solve. So, it's not going to be changed overnight, but, that type of feedback really does help, to our cause, and what we're trying to do, because ultimately, we have, created a great network where, we can connect folks and we can kind of be that support. And we've, we're fortunate to attend ISC, and, again, not many caregiver survivors are in presence, but being able to kind of know, who folks like, the gentleman who reached out, who's a listener, who might be able to support, and there's services out there, but I think that's the issue of, so many things happening in silos right now where, we really need, as a patient and caregiver community, need to kind of come together as one to make our voices heard. So, I know that's happening, not only on the clinical front, to advance research, really trying to come together and understand, at a population level, what needs to come together to be able to change. That needs to happen at an advocacy level as well. There's brilliant groups all around the country, all around the world, kind of supporting the same mission, but we need to be one voice to make this change. And, that's something I'm really looking forward to discussing with Senator Lujan, when we have him on, of what needs to change, what voices do we need to rally to really try to drive this. And
True.
Yeah. So let's kind of, transition. Let's, get into this episode. We were fortunate to connect prior to ISC with Eva Mistry. She's a neurologist from the University of Cincinnati. Her work really, as I allude to in our discussion today, has been focused within the research realm of blood pressure control. She was awarded, actually, at ISC, the Robert E. Siekert New Investigator Award in stroke. So really great accomplishment to Dr. Mistry. And although, she'll talk to some of the upcoming research that she has, which is focused around, something that, we never really think about. But again, when it comes to that clinical lens of what's being researched, there's the thrombectomy service of kind of getting that quick treatment as soon as you get into the hospital, right? Like it's been shown this works. We need to get this, to all patients who arrive in the ED within a certain time period. But no research thus far has been done on folks who have an underlying condition or disability prior to that stroke. So that's what Dr. Mistry is now working on with a grant from PCORI, which, if you're not familiar with PCORI, it's an acronym with an organization that's all around patient-centered outcomes. So to be granted a piece of funding through PCORI, your research needs to be tied to advancing patient outcomes. And they've done some great work. But again, more needs to be done, right? But I think Dr. Mistry, the team at University of Cincinnati Health, like they're on a path and doing some great stuff. So I don't know if you have anything else to kind of mention before we get into this, but
no, it was a great intro. Just loved her magic wand. I loved her idea around, and you'll hear her talk about a learning health platform, and maybe that is something that, in terms of talking about accelerating care delivery while we're doing the research. So that was and always appreciate when a group and someone, that's in the field and doing great work on the clinical side appreciates the work that we're doing on the advocacy side. So a lot of work to do, but this was a great interview and I think everyone's going to enjoy it.
Perfect. Let's get into it. Hi, Eva, and welcome to the No Stroke podcast.
Hi, thank you for having me.
Yeah, absolutely. So, before we get started, first off, we had the pleasure of being able to run into you at ISC quickly in the hallway as you were making a dash for maybe the plane. I'm not quite sure, so I hope I didn't startle you. But I had the pleasure of seeing you on stage as well. So first, just wanted to say congratulations on the Robert G. Siekert Award for New Investigator. It's quite the accomplishment.
Thank you. No, it was great to run into you too. I'm glad we did.
Yeah. So, we'll dive into, the research that, kind of got you on stage at ISC on the Friday. But before we jump into this, let's kind of backtrack and, let the audience kind of hear a little bit about your background and what's brought you to your current role at University of Cincinnati.
Yeah, so I grew up in India, and I went to medical school there, and came to the United States in Houston for my residency at Houston Methodist Hospital and fellowship at Cincinnati. And then I left for a couple, 3 years at Vanderbilt. I was a faculty there and came back a little over a year and a half ago back to Cincinnati. And that's how I'm here. The reason why I'm in Cincinnati is because during my residency, I realized that I really enjoyed stroke research and especially acute stroke research, and had some question. In fact, I built my blood pressure question inquiry starting in my residency, kind of built it up until this trial that you saw at ISC. And so I wanted to continue that kind of involvement in acute stroke research. And I've kind of branched out, as you know, in several other areas now. And that kind of attracted me to Cincinnati, and that's why I've stayed. Why stroke and why stroke research is, I think it's kind of, bits and pieces that you gather in your life kind of land you to a place, and a lot of personal stories, a lot of people that I worked with and who inspired me here and there. All of that has played a big and small role in where I am, and where I am is a great place. I truly enjoy what I do. So, yeah.
Well, thank you for sharing your why, and thank you for joining us today. I know, just getting back from trip the first week back after conference is always a juggle trying to get back into the system. So before we get into your research and all the great work you're doing, can you, for our audience, is there, what's something that you might want to share about what you do when you're on your free time, if you have any?
I have free time, not so much mine though. I have two little ones. They're 4.5 and 2.5, and my husband is a neurosurgeon. So we're busy over here in Mistry household, and whenever we have free time, we just love to spend with our kids and take them to places and do fun activities with them, which is not kind of the fun piece, but it matters to us. So yeah.
And are you grooming new neurologists for 2050?
They both have their own personalities, and we'll let them do whatever excites them and whatever they're good at. And they're too young, but they're their own people. So yeah, we'll see what happens. We just want them to be
Beautiful response. Very nice. Hopefully they like, the cold of Cincinnati, but that's what
they
they
wear
get.
shorts outside in December and January, so they're Midwesterners.
That's definitely a thing. For sure.
So, I don't, Cincinnati and, UC Health has, kind of gotten a lot of attention lately. And not to, say it's a good thing, right? Whenever someone ends up in the hospital, usually not for a positive reason. But, gentleman, Damar Hamlin, NFL player, he was treated at UC Health recently. And it must mean a lot, as an organization, to get the attention, but for you and your colleagues to have that, the ability to kind of show your work and have some of this get highlighted. Unfortunately, when it comes to stroke, there's not too many kind of patient stories, and that the care team really getting recognized for such the amazing work that you do. But I do know you've been selected, you're kind of one of the first health systems in the region to receive the Joint Commission certification for Comprehensive Stroke Center. And one of the reasons, as you've grown, and obviously, your ability to, manage and get with the guidelines and have great statistics of door to needle time and kind of that acute treatment. One thing that I saw as I was doing a bit of research is that you have one of the region's first mobile stroke units. And we just spoke with Jeffrey Donnan and Stephen Davis from Australia, who are taking imaging and putting it into airplanes across rural Australia. But I'd love for you to speak to, the success of the mobile stroke unit, in the Cincinnati region, and maybe just because, like, are there barriers with this as well, right? So obviously success is you're able to get people to the hospital quicker, but I'd love to just hear what that program has looked like since it's been implemented.
Yeah, mobile stroke unit is I would call it one of the latest victories of our stroke team. As you know, we have a long history of victories at UC. We were the first ones and enrolled the highest number of patients in the original TPA trials in an INDS in 1990s, and it all started there. So we're very proud of doing historic stuff, and I would say that MSU has been one of the latest ones here. It's definitely been a very successful program. Chris Richards, who is an emergency medicine physician, directs the program, and you've seen stories of dramatic recovery in young patients when they get treated within that golden hour of that very, very early hour of their stroke onset, which is what the purpose of the stroke unit is. And so we're very proud of the work that the doctors and nurses and the staff that does in the mobile stroke unit. One really good part about our stroke unit recently is that we are actually able to do research studies in stroke unit as well. So one of the most recent examples is our team and as national PI is Joe Broderick for this study called FASTEST. It's an NIH-funded study on intracerebral hemorrhage, so bleeding kind of strokes. And it's giving a medication to stop the bleeding from expanding. And it has to happen within 2 hours of the onset. So it's very early. And so we are able to use mobile stroke unit for those kinds of ultra early stroke studies, which is really great. And if it works, then it might be kind of just be changing how we treat bleeding kinds of strokes and things like that. So definitely great successes there. Lots of work to do still because it's new, but But we'll have some good statistical data on what the exact impact in terms of minutes and disability save that we're making. We're still kind of new, so.
Yeah. Well, it's, great to hear, the abilities, to advance research, right? Because that's, as we'll get into it with some of your upcoming research, there's often so many barriers for stroke patients to get enrolled in some of this research, and technology and, services like a mobile stroke unit could only help. So fascinating to hear. Just one side note on the mobile stroke units, like, it's interesting when you think about, we often say for a patient, a stroke is a stroke, no matter where you have it, right? But what matters about where you have it is that care delivery, right? Both from the acute phase all the way through post rehab. So, when we look at the makeup of these mobile stroke units, I'm here in New York City, and Mount Sinai has a mobile stroke unit that, again, for the Mount Sinai health system, which is great. But if I have a stroke and I pick up the phone and I get tied into not to put down NYU Langone, but maybe they don't have a mobile stroke unit, right? Like, how could it's often, the hospital system who has this, right? Like, do you think there's a way that, it could expand past, just the hospital system itself? And I'm sure it's like how the ambulance systems are set up and everything, but I guess, like, what's your take on how you could get more patients eligible, like get more of these, have a better chance of a survivor, no matter where they are, to get a mobile stroke unit at their house?
Most of the hospital systems, the mobile stroke units are not really kind of tied to a hospital system,
Okay.
although a hospital system has, and by law, they have to allow patients to go whichever hospital system they choose to go to. So for example, UC Stroke Team mobile stroke unit will deliver patients to hospitals across the region, depending on the patient preference and where they will be best served in terms of the time of transport and things like that. So they definitely follow the EMS algorithms. It is definitely not specific to a hospital system. I have never lived in New York, so I can't speak for the city and how it operates, but benefits of mobile stroke unit in terms of time saved are very region specific and geography specific. So that's definitely have to be kept in mind. And you're absolutely correct that the people who need it the most, the people who are rural and away from the cities, who are not within the reach of this city-based EMS services and thereby not eligible for mobile stroke units per se, are the ones still kind of left out from that care. And we definitely have to work hard to make sure that we reach them. I think that the scanner in the airplane is a fantastic idea. I hope that we get there, maybe in the helicopters one day, I don't know. But definitely community education and intervention there, recognition of symptoms, all of those things play a huge role in those settings. But I agree that we need to do better to reach those populations that are not yet reached by mobile stroke units per se.
Thank you for sharing that. Let's talk a little bit more. I really want you to put the spotlight on your research focus now. And can you talk about your PCORI funded, it's multi-site. Tell us more about, where that is. Maybe give us the short notes on, the design of the study and just, what stage it's at right now.
Definitely. We are very fortunate that PCORI chose to fund us because, in my biased opinion, it is a very important study. The study itself is simple. The question is fairly simple. We want to understand if this endovascular stroke treatment that you probably already know by now, that it's a pretty effective treatment for acute stroke. It's basically going in with a catheter and bringing the blood clot out, a large blood clot out from the brain that's causing a stroke. And it's changed the way how we practice stroke care and the outcomes of our stroke patients drastically. Unfortunately, the way trials were done and back in 2015 that were presented, excluded patients with any level of baseline disability from enrollment in the trials. And the way we write guidelines across the globe is kind of just follow what the trials did, because that's what we have evidence for, and that's what the guidelines are for. They just kind of summarize and tell you what the evidence looks like. And so consequently, it made it into the guidelines that endovascular treatment is recommended by the highest class and level of evidence for patients who meet X number of criteria. That's according to those trial inclusion exclusion criteria, and they specifically say that pre-stroke disability is one of those criteria, as in patients who have a baseline modified Rankin score of 0 to 1 are eligible, and 0 to 1 means no disability, are eligible for this treatment. And so what happens is clinicians kind of take that as a face value, as they should. These are really great guidances for clinical practice. And what happens is whenever at bedside we talk about offering endovascular treatment to, say, somebody who's been wheelchair bound or when walking with a walker or has dementia and can't take care of themselves, always involves, but they have a pre-stroke disability. And what are we kind of, are we saving enough? And is this, the word resources, worth it? And so our idea is to generate one of a kind prospective observational 12-center data on the comparative effectiveness. So we're not kind of randomly assigning patients to get therapy versus not. We're just kind of collecting data if they got therapy versus not in routine clinical care, and then collecting a lot of details about their baseline functioning, not just the modified Rankin score, but detailed granular data about what they were able to do, what their social life looked like, what was their family support, education level, what was their exact impairment of functioning. Were they, had a knee replacement and had pain in their limb, or were they having dementia and just couldn't communicate? What was the reason why they landed at that MRS-3? And so we're collecting all of those data and then following these patients out to 90 days to collect how they did at 90 days, not just again in terms of MRS, but also very, very granular data about what their cognition looks like or what their quality of life looks like, things like that, to kind of just give the community a sense of if we are, doing the right thing by offering treatment to these patients, and if not, then what are some of the characteristics that determine that differential treatment effect? So in that sense, the study design and the question is fairly simple, but overarching goal, which I hope we will be able to do, is with this data, we'll be able to arm researchers in future to not reflexively say that because we're doing this novel stroke intervention study, we're going to exclude patients with disability from this randomized clinical trial, which is actually very common. In fact, we have seen that more than 80%, close to 90% of clinical trials in stroke, no matter if they're acute or prevention trials, exclude patients with a baseline disability from research. And so we create evidence gaps and clinical care gaps for these patients. So our overarching goal is that we will arm researcher with data that they can use, hopefully, to not reflexively say that we're going to exclude patients with disabilities from all kinds of research, because disability exclusion criteria goes deeper than just having disability. Because if you think about who has disability in the United States, these are older individuals, these are women, these are minorities, and so it creates health disparities without the researcher intending to do it. And so that's the overarching goal.
Yeah, and just when you think of one predisposed risk of stroke, like the underlying conditions of what often brings a stroke patient through the doors is these factors that are currently not being studied, right? Do you have a sense of, what percentage of, stroke population right now would kind of fall within this predisposed risk and have the disability?
By some estimates, up to 1/3 of our acute stroke population has a pre-existing disability that includes having a prior stroke, and obviously all other kinds of diseases and causes of disability. So some estimates say about 15%, some say around 30%. So a fair number of patients.
Interesting. And so what sites are you guys, obviously this at UC Health, what other health systems are you partnering with on this?
And they're geographically kind of diverse, these sites. And I might not be able to name all 12, but I'll try. So UC Health, we have UCLA, Mount Sinai, University of Washington, Barrow at Phoenix, West Virginia University, Vanderbilt, University of Miami, Columbia. Who else am I forgetting?
I'm not counting if you are.
Okay, I got 9. Okay, I'm clearly forgetting.
That is quite diverse though.
Okay.
So yeah, that's great to hear.
All
Yeah,
across is the point. Yeah.
very good. Cool. So I think, on that, let's take a short break and but no, that's fine. All right, let's take a quick break, and when we get back, we'll dive into the research that you're presenting at ISC.
Sure.
All right, and welcome back. We are here with Eva Mistry. So at the break, Eva, you remembered the other two centers, so I'll let you share now.
I did. They were Hartford Health and Yale. So.
Right. We have friends at both, so glad to hear that, it multi-site and, some really, really great, piece of research that you're going to be doing that I think is going to help, open the field down the road. So kudos to you. And with this research and, you've recently, this year just got awarded the New Investigator Award in Stroke. And you were on stage at ISC. I have to say, you had a tough follow. The gentleman who presented before you, Senator Ben Ray Lujan, was, the only survivor voice that was shared at ISC. It was great to hear his story, super heartfelt, motivating, and I think with his understanding of these gaps in care, especially post-stroke treatment, I'd love to hear, his thoughts on that and kind of how he's, rallying that voice and hopefully being able to drive some change. So while we'd love to hear more stroke survivors and patient perspectives on stage at ISC, it was, kudos to AHA for getting him and being able to share that story. I think it was heartfelt. But let's talk about you, Eva. This is your podcast, so let's hear about your recent award and the study you presented, looking at blood pressure after endovascular stroke treatment. So if you want to kind of tee that up, what the aim of that study was, and then some of the results that you presented on stage.
Yes. So we discussed before that in 2015, we had these positive trials of endovascular stroke treatment, drastic treatment effects. If you look at the data, you find that about 50% of patients, even after receiving this therapy, remain disabled or die at 90 days. So even though it's very, very effective, we could still do better for these patients. And since then, because of that reason, we have been on a quest to kind of see what else can we do, what else can we optimize to help move that needle a little bit more. And one of the things that we have found that medical care or procedural care might affect outcomes specifically, we have a ton of observational evidence that shows that if you have higher blood pressure after this treatment, that is associated with worse outcomes. Obviously, this is observational evidence, and we have done a very large study, kind of as a dose finding study of this to understand if there's exact levels of blood pressure that can associate or dichotomize good versus bad outcomes. And we found that that number was around 158 or practically 160. So if you had a single blood pressure value over 160 within that first 24 hours after getting endovascular treatment, then you had higher chances of having worse outcomes at 90 days. And with these findings, we wanted to kind of move them forward in an interventional randomized study to understand, as a first step, if artificially lowering the blood pressure, giving the patients medications to keep their blood pressure below a certain level, not just what the brain does or the body does, but actually giving them medicines to help the blood pressure lower. Are we harming these patients? Is this even safe to do? And two, how promising is this strategy to move forward in a larger thousands of patients trial? Is this worth investing millions of dollars over? And so that is the reason why we designed BEST2, which is what we call a phase 2 trial, which is an early phase trial, which is kind of understanding if your intervention is feasible, if is it safe, or is it worth moving forward? All of those kinds of questions are early phase trials. These are not pivotal trials, which definitely answer a question yes or no. So just a key difference there about the design. It's a phase 2 design trial. It is what we call a futility trial. And you may have caught that on the stage a little bit, that it is by design, we set out to understand if moving the lower blood pressure targets as a strategy to improve patient outcomes is futile. And we define futile if A, we find evidence of harm, and B, if we find that there is a very low chance that a future trial, and we calculate it using trial simulations based on the data that we collect, on trial simulations, if we find that the chance of having a large trial positive is less than 25%, then we say that we don't move forward because it's probably not worth, investing millions of more dollars behind this. So in my biased opinion, it's a cool design in that way. And we, as you know, enrolled 120 patients at 3 centers. Our intervention groups were standard blood pressure value, high of less than equal to 180, and then 2 moderate blood pressure groups, less than 160 and less than 140. Those were to be maintained for 24 hours after the intervention started, using nicardipine as the first line agent, which is a blood pressure medicine that's given as a continuous infusion through intravenous route.
I just had a quick follow-up question on that, because when I was trying to understand, is the thought, and first of all, I didn't know that you could really target, so you're targeting systolic blood pressure, the top. Mm-hmm. Is the thought that if you adjust too low, does it have to do with perfusion? What is the risk?
That's a great question. 2 points there. In terms of the intervention itself, our goal was to just target the high number. So our goal was to not let the blood pressure creep above the randomly assigned blood pressure target. We didn't target the lower number of the blood pressure per se, except for we asked and protocolized that the blood pressure medicine be peeled off if the patient's blood pressure was reaching lower than the highest number of the next group that's below them. So that's just the key point over there. But yes, it all comes down to what we call cerebral autoregulation, which is the fancy term for the fact that brain has this beautiful property of maintaining its blood flow at a constant level over a large, range of systemic blood pressure. And so because brain is such a sensitive organ, even if your blood pressure goes down to 100 or over 200, in normal people like me and you, our brains auto-regulate the blood flow to the brain by constricting or dilating the blood vessels to a certain fixed milliliters per gram of brain tissue. And that is called autoregulation. The thought is that if we artificially give the blood pressure lowering medicines, we are probably messing with this beautiful property that the brain has. And thereby, we're probably making the blood flow less than it should have been per the brain's own criteria. The brain says that you need this much. That's why we're increasing this blood pressure and we're dilating or constricting these blood vessels. We're giving the blood pressure medication, lowering the systemic blood pressure, and we're just messing it all up. And the first kind of clue of messing it up is that you would have higher volumes or higher size of the stroke per se, which is what the brain was trying to save in the first place. You lower the blood pressure, you compromise the blood flow to the brain further, and you might have higher volumes of strokes. And so that's why it was one of our primary outcomes, was the exact volume of stroke that the patients ended up having at 36 hours. We wanted to mechanistically understand if we're causing harm by lowering blood pressure and thereby increasing the volumes of stroke.
Thank you. That's a great, perfect explanation. I get it. that it just goes to show I'm glad folks like yourself are studying this, because it's such a wonderful organ that we know we're still learning about, you know. Mike, you were there for the award. Why don't you talk a little bit about, let's switch gears to the recognition a little bit, that did you see Dr. Mistry's award?
Yeah. So I think this was, it was in relation to this study.
It was, okay.
Yeah. So yeah, you know, it was, face was plastered everywhere outside the hall. You know, with that award, you know, you also, you know, were in attendance for the 3 days at the conference. You know, so I'd be curious, you know, you are, seems like, you know, we might be calling you the blood pressure guru of, you know, of our past guests, right? I mean, it's a niche for you, right? But you know, was there anything else, you know, in the 3 days that you were there, from a trial perspective, or, you know, new research coming out that kind of caught your eye that you'd like to share?
Let me tell you about the couple of cool things that we presented that I think is great. And then also I was very happy to see some of the other data in terms of what we are doing. We presented this session on the StrokeNet thrombectomy platform, which is a huge platform trial funded by the NIH and NDS, conducted through the NIH StrokeNet. As you know, we're very heavily involved in NIH StrokeNet over here at UC. And so we did a session on kind of educating the community about the various aspects of this very complex platform trial. It is complex by design for a reason, because it's extremely efficient. It's you may have heard about the REMAP-CAP or active trials for COVID, for example, following very similar suit. And so we're excited about that. The other thing we presented is our upcoming trial on a very novel, a very promising lytic drug that we think might replace TPA or TNK in the next 10 years. And we're starting that trial later this year. We're expecting our notice of award. We're approved for funding by NIH, and this drug is developed with NIH funding as well. So it's pretty cool, just like TNK and TPA, or TPA, I should say. So we're very excited about that. In terms of other things, I thought that the SPAN session was very interesting about neuroprotection and uric acid was great. Obviously, the large core trials, which was what I thought that you were talking about earlier, a hard suit to follow. I didn't realize that you were talking about the senator's speech, which was definitely a very hard suit to follow. I don't know if people were listening to my talk at that point anyway, but large core trials were very interesting. We have a ton to digest there in terms of how those trials apply to our practice and how things are going to change, hopefully for the better. But those were very interesting. The confirmation of TNK being non-inferior to alteplase in the Chinese trial was interesting to me as well. We knew it. We have switched to TNK in our region, what was a nice cherry on the top. But yeah, some of those were my favorite ones.
Very good. Yeah, that's what I was meant with the senator's speech. I think people were tuned in. Don't worry. It was you had everybody's attention. So yeah, I think, you know, it's been, you know, fascinating to hear your work. Obviously, you know, you've been in this field and, you know, really pushing the needle in a few important areas for research. You know, with that in mind, you know, is there anything kind of late breaking, you know, out of UC Health that you have, you know, planned from a research perspective over the next, you know, year or two?
Yeah,
obviously the ongoing trials, but
we always have a ton going on. So, the PCORI grant, excited about that. The novel lytic phase 2 trial, we're very excited about that. Fastest, the ICH trial that we're leading here, excited about that as well. We have a very nice biomarker study of identifying biomarkers for stroke recovery. We're very excited about that. We do a ton of hemorrhagic stroke genetic epidemiology work, and hopefully we'll have a good therapeutic target from that work coming out in the next few years too. So lots of going on, lots to do still for our patients. And so hope to make an impact.
great. And are most of these studies, from at least from your center's point of view, like, are those all on site? Do you have any kind of remote trials or anything that folks could maybe learn about?
Most of our studies are multi-center. So, we do have single center studies at our site, but I didn't mention them. They're fairly pilot, and the studies that I mentioned are large, big, multi-center studies.
Yeah, that biomarker study, that's quite interesting. I know there's a few companies, one that we spoke to, that's trying to, well, you just saw, I think in the news recently, right before ISC, they announced the Fast AI, which is like a smartphone app to try to track face droop, arm weakness, things like that. There's a few wearable companies out there as well. So yeah, we'll have to get you back on. Sounds like there's some great research coming down the pipeline.
We're excited about it.
Cool. So I think with that, we'll kind of end here. Each episode we do end with our magic wand question. So the way that's designed is, you have this magic wand that could go and really make any change that you'd like, and, be as creative, with it as you'd like. But, the question pertains to, how would you take that magic wand to redesign the stroke care pathway?
Stroke care pathway, and where I'm assuming you mean stroke clinical care pathway, not the way we do stroke research, because I have two different answers for that.
Fair. You could take it in the research angle.
Okay. Well, for research angle, I think that the magic wand, and I don't know this will ever happen, is I would love to have a kind of a nationwide multi-center perpetual learning health platform where we do experiment embedded in the clinical care, obviously within the constraints of known therapeutics. And just have this perpetual system that learns on itself about what works in what system and what doesn't, and also provides this ability to do randomized studies as a whole infrastructure that's embedded within the clinical care, without adding the research specific costs to do some of the things. And so just kind of making it cost and time efficient while constantly learning from it. So that would be my dream to do it, but I don't know if it will ever happen.
That's the magic wand.
Yeah, great answer. And driving and delivering outcomes, and maybe saving some time in the process too. Fantastic. So this has been a great, it's been wonderful meeting you. I know Mike and I ran into you at conference briefly, but I can see, why you received that well-deserved award at conference of the new Investigator Award in Stroke by the ISC. So is there anything you want to add in closing? I know we want to be aware of your time, but we can put all your resources in the show links, but I'll give you the last word here before we wrap up.
No, just thank you for having me, and thank you for all the work that you do to kind of increase the awareness around the disease and cutting edge therapeutics. I know our patients are disadvantaged, like you said before, than cancer, and that's kind of rings so true. The population that gets affected by the disease is not, kind of glamorous, and so it kind of doesn't get the limelight that it deserves. Our patients are not the ones that are going to have their family members researching heavily about the novel cutting edge things that are happening. the setting is very different. It's acute. You know, we don't have relationships with these patients. They don't have a relationship with us. They're seeing us for the first time in their life while they're suffering from this disabling symptom. So it's hard to do it as against cancer, where you have existing trust and relationship with the clinician. So work like this is so important to kind of get that awareness out and trust built, honestly, with the community. So we really appreciate that.
Thank you.
Yeah.
You know, that means a lot. You know, I think you hit the nail on the head, right? It's, you know, stroke is so unexpected, but, you know, the work that's being done, you know, put the trust in, you know, amazing folks like you in the clinic and in these hospitals to take care of, you know, the acute phase. But, you know, I think it's also a lot of work to be done there on the post end, right? Because you then are with them for life oftentimes. So, you know, thank you for the words. You know, it kind of helps support our mission, what we're trying to do. And, you know, maybe we could make stroke sexy or something, you know, make it, you know, because it's the black sheep of care right now, but a lot to be done. So thank you for all your work and, you know, coming on here to share everything. Again, sounds like some great stuff down the line for you. So we'd love to have you back on.
Thank you.
Thank you.
Thanks, Eva.